presentation and on you.
Yeah, no, it's really a pleasure. I've been preparing my input for that. It looks like it's a very good event as well. So.
Okay, great. And my parliament is meanwhile that well organized that they sent me the link to this tomorrow's webinar and said, that could be interesting for you. And I said, yes, for sure, but I cannot make it.
Yeah, so tomorrow it's the PES women, right? Yeah.
Yes, as far as I understood, yeah.
No, it looks like it's a very deep internal thinking that they're going into about SRHR. So it's really nice to see that.
Yeah, and you know Sita Gurmai, who is the chairwoman, she is also the general representative on violence against women at PACE. So she's also very involved in all the Istanbul Convention issues and very active on that.
Yeah.
Not only on that, on SRH in general.
Yeah.
And she's Hungarian, where they do not have an easy life.
No, they barely have SRHR there. So
yeah.
No, I just find it a little bit funny that two of the main guests at the PES Women are both men. It's myself and Fred Matic.
Yeah, indeed.
But, okay.
Yeah, but
yeah, that's how it worked out.
Yeah, exactly.
I just want to say that we have already some attendees. We have 4 attendees, and we are on YouTube now, live.
Okay, thank you.
So, yeah. We have also Miss Anda Chaksa from Latvia to promote.
And Marina, those who would like to take the floor later at the event, they have to be promoted by you as well?
We can unmute them. Yes, we will promote and unmute them.
Okay,
yes.
Wonderful. Thank you.
What? Oh, yeah. No.
I want to wish you a very good afternoon and greetings from sunny Vienna. It is my pleasure to welcome you to the launch of our EPF report on access to contraception in Europe during the COVID-19 pandemic. As you might know, we will celebrate on Sunday, the 26th of September, the World Contraception Day. So it's a good occasion to focus on this issue especially. So my name is Petra Beyer. I'm a member of the Austrian Parliament. I'm president of EPF, and also I'm chairing the Committee on Equality and Non-Discrimination at the Parliamentary Assembly of the Council of Europe. EPF, the European Parliamentary Forum on Sexual and Reproductive Rights, is an organization bringing together MPs from all over Europe, which are champions in sexual and reproductive health and rights issue, both within their countries, but also when it comes to development cooperation abroad. We have all party groups in about 30 European countries, and all of those focus on issues like violence against women, access to contraceptions, legal and safe abortion, as evidence-based sexuality education, LGBTIQ rights, and we also campaign against these forces who want to restore the natural order and subordinate women under men and deprive them from all their fundamental human rights. EPF publishes, for instance, the Contraceptive Atlas, which quite clearly shows how easy or not easy the access to information about contraception and contraception itself is in different European countries. And it also shows whether there is progress in policies that brings contraceptive closer to people. So the study we will present today, which focuses on hurdles, on obstacles, additional obstacles created by the COVID-19 pandemic, will be a kind of complementary information about that. And it is my pleasure to guide you through this webinar this afternoon. So the first one I would like to give the floor is Neil Tata. Neil is the secretary of EPF, and he will give you the presentation of the EPF report on access to contraception in Europe during the COVID-19 pandemic. Please, over to you, Neil.
Thank you very much, Petra. It's wonderful to be here with all of you, and also to mark this year's World Contraception Day a little bit early this year because otherwise it falls on a weekend. So we thought we'll meet today, and we thought that for this year what we would do is take a look at what has the COVID pandemic, the COVID-19 pandemic, impact been on access to contraception. So we know we have been hearing about this anecdotally from different countries around Europe. So we thought, well, we'll take a more systematic look at this issue, and then produce what the results that we have in a report. And so this is what I'll be doing here today. And next slide, please. Thank you. So just a snapshot to remember what COVID-19 was like in Europe. So we're still in it in some places. We're only now gently coming out of it. But just as a reminder on how it impacts possibly contraception, as we all know, there were great disruptions. Among these disruptions, healthcare services were overwhelmed. They had to meet the urgent needs of sick people. There were lockdowns in the vast majority of countries around Europe, and if not around the world. And these had sweeping consequences on most sectors of the economy and of society. People were afraid and financially and socially strained. So remember, many people lost their jobs during this pandemic. But there were ways of compensating for the social distancing we all had to go through, and then that was resorting to digital solutions in order to continue functioning in some ways, such as this webinar. We discovered we all had certain IT skills that had up until then lain dormant. We also saw that with the onset of the pandemic, that the underlying gaps in resources, organizations, and policies that existed within our countries were all of a sudden exposed to the broad daylight. We knew that they were there, but now they became really startling realities. So next slide, please. Next, yeah, okay. So just a little introduction as to why taking a look on the impact of the COVID pandemic on contraception is important. So access and choice in relation to contraception is integral to sexual and reproductive health and rights, gender equality, and a woman's ability to make and act on decisions about her body, health, and childbearing preferences. Also, let's remember that contraception needs to be constantly available to women so that they can continue to benefit from it, so that if there's a disruption, then it can have negative impacts on their health and well-being. At the same time, contraception is itself sensitive to disruptions in terms of production, distribution, and provision. So we thought there's something there that we need to take a look at. Next slide. So in terms of the methodology that we've adopted, it's rather quite straightforward. So we were able to identify 13 reports at national level or international level that talked about contraception in some way, either directly or indirectly, or within a part of a wider package of issues. There were also 14 surveys that have been done in some way over the past year. And then our researcher conducted 3 more in-depth interviews, and then all of this within the context of an overall desk review. And this was to see what information is out there about the impact of the COVID pandemic and the associated restrictions on access to contraception. And the information came to us mainly from national partners, regional and international organizations, and covers the period from June to September 2021. Next slide. So first main finding, and this is perhaps going into the obvious, but it is that no country in Europe has comprehensively and systematically monitored how access to contraception had been affected by the COVID pandemic and the associated restrictions that came with that. So no country was following this at all. But we were still able to tease out some anecdotes from different countries, so that there were studies done in Latvia, UK, Sweden, and from that we were able to identify certain things, and we share with you these things that we were able to identify, and you can see for yourselves how they may or may not be relevant or applicable in your own country. Next slide. So first, a number of key barriers were identified on access to contraception. So first, very obviously, there was the user's fear of COVID-19, particularly in the first phase of lockdown, and then also the respect for the restrictions, the social distancing, and then also a concern of not wanting to be a burden on the health system. Whereas, as you remember, people were on respirators and dying. So this may seem a small issue in compared to what we were all seeing was an overstretched health system. Another key barrier that we identified were the service provision points in terms of clinics and their opening hours. So in some cases, the clinics simply shut down. In some cases, the clinics had different opening hours. And then related to this was a lack of clear communication from public authorities about how these health services were reorganized. So you have this combination of lack of information and changed to the normal status, which made it so that it made it practically challenging to access sexual reproductive health services. Then a fourth key barrier is that in some countries, there were stockouts reported in certain pharmacies. So they just ran out of the products. In a fifth key barrier were financial barriers due to loss of income. Remember, there were millions of people who lost their income. And so all of a sudden in countries, especially where contraception is not covered by the national health system, then the loss of income plus needing to pay for it out of pocket became an additional barrier. And the pre-existing gaps that existed in terms of accessing contraception were made even worse by these challenges brought on by the pandemic. Next slide. But we also identified perhaps 5 key enabling factors which public authorities were able to put in place, which were able to smooth access to contraception. First of all, telemedicine to provide contraceptive care over the phone, social media, or other digital means that was pioneered in several different countries and proved to be quite successful. There was also greater flexibility from healthcare services, such as mailing prescriptions in the post or sending them directly to the pharmacy. There were also good campaigns to reach out in different languages to communicate about how to access these services. There were changes in routines to ensure access to long-acting reversible contraceptions, for example, in some countries, offering it to women in a postpartum situation. And then in some countries, we also saw that there was a push by public authorities to allocate extra funds to ensure access, particularly to underserved groups. However, for certain types of contraception, for example, the long-acting reversible contraception, and for those who may not know what that is, that's, for example, implants or IUDs, intrauterine devices. For those types of contraception, which are long-acting and the most effective, that still requires an in-person interaction between the patient and a medical practitioner. And that in-person interaction, as you can imagine, was more limited during the periods of lockdown and pandemic and restrictions than other forms of contraception. So that remained a specific challenge during that we were able to identify in this report. Next slide. And now also there's what I've just described overall, but then we just need to consider that all of this became that much worse for specific sets of marginalized groups. And these marginalized groups are specifically those women at risk of socio and economic exclusion, younger women and adolescent girls. Maybe some of them would have been confined at home with their parents and in an uncomfortable situation having to discuss contraception within that context. Women with disabilities, rural women who may be far away from service provision points, refugee, migrant, and undocumented women, ethnic minorities, Roma and Black and ethnic minority women, and also women. This is perhaps a new category specifically due to COVID, but the women who were previously economically secure and then find themselves in an economically vulnerable position because of a loss of income due to unemployment or reduction in economic activity resulting from COVID. So these groups felt these challenges particularly acutely. Next slide. If we take a look at long-acting reversible contraceptions, what we were able to find there is perhaps the most startling in terms of the findings on contraception is that there were specifically delayed fittings and removals due to recommendations that this could wait. This was initially especially during the first phase of lockdowns, when the health systems were really being overwhelmed. The recommendation from some public authorities is that this is non-urgent, so don't worry about this. It can wait. It was inserting or removing LARCs was not considered to be part of the planned emergency services. In some cases, these types of contraceptions are not fully covered under health insurance plans. And then also there was a lack of trained staff and backlogs and becoming in terms of what the staff could do, and which meant that this became part of a specialized type of healthcare rather than integrated into the primary healthcare setting. Next slide. So based on these findings about how access to contraception was particularly affected, there are 10 recommendations that we were able to pull together from the national experiences that we were able to identify in this report. So among these 10 recommendations, there was one to guarantee access to contraception through national healthcare systems. This is a long-standing recommendation, but it becomes all the more relevant now. Ensure that access to modern methods of contraception is defined as essential healthcare, and also that it should be reimbursed even in times of crisis. Include the availability of healthcare professionals in policies for essential health service delivery. Strengthen primary healthcare organizations and funding and integrate contraceptive care within that. identify and track gaps to universal contraception through comprehensive monitoring, including underserved groups. So this, again, I go back to the first point, almost no country engaged in any serious monitoring of this specific issue. Next slide. Yes, and I'll finish with these remaining 5 recommendations. Ensure that young people have access to contraception and a method of their choice. Again, another long-standing recommendation, but even more relevant now. Continue to provide sexual reproductive health care, including contraceptive counseling via telemedicine, and improve the tools already in place. So that's one of the lessons we learned of the pandemic, that we can do this. Recognize that access to information is a central component of healthcare systems, and adapt communications to make information accessible to all. This became particularly important when people needed information as to what is open, what is not, what is changed, what is different, and this needs to be improved. Build on the lessons of the COVID-19 pandemic to develop solutions to sustain access to contraception. So here again, there were these telemedicine solutions I was talking about. We need to see how we can then make these permanent, since these are good solutions that can ease access to contraception. And then finally, also encourage patients and clients and others to continue to seek sexual and reproductive health care, even during a pandemic, that this is not a luxury issue or an unimportant issue. It is part of, it's a vital part of one's well-being. So we end with these 10 recommendations. And with this, I would just like to thank our national and regional partners and our sponsor for this report, Organon. So thank you.
Yeah, thank you very much, Neil. And indeed, SRHR and contraceptives are not the cherry on the crime. They are essential indeed. And we will now see an animated infographic that brings together all the information Neil shared with us as in a nutshell, please. Yeah, great. Thank you very much for this very nice way how to summarize all the information. And I will now hand over to Christine Michelsen. She is Associate Professor at the International Center for Reproductive Health at the University of Ghent, where also our former chair, Petra de Sutter, was active in her time as a gynecologist. It's always a tongue twister. And she will bring us some more information about impact on individuals. So Christine, over to you, please.
Thank you very much, Petra. Can you just confirm that you can see my screen with the PowerPoint presentation on it? Perfect. Thank you so much, Petra and EPF, for inviting me to present the study that I'm quite passionate about and I've been working on a lot in the past year. The study is called iShare. It's a multi-country study on sexual and reproductive health during COVID, but I will only be presenting a small part of the study and focus on access to contraceptives. But let me take you back a bit to how this started. As you know, when the COVID pandemic hit early 2020, there were quite a few expectations and projections that it would have a major impact on access to SRH services. It would both affect the supply side of the services as well as the demand side. and lots of projections were published, lots of commentaries were published, but there were actually not a lot of actual studies getting initiated that actually would measure the impact on the ground. So what I did was send out an email to a network that I'm part of, the Academic Network for Sexual and Reproductive Health and Rights Policy Research, ANSWER. And quite a few of the partners in that network responded positively towards setting up a study. And then a few weeks later, I came across a call for a similar initiative from Dr. Joseph Tucker, Professor Joseph Tucker from the London School of Hygiene and Tropical Medicine, and we joined forces and we set up this study. There's academic institutions in 32 countries involved, and we have collected data in 30 countries around the world. Also, as a small side note, that we did this unfunded. We had no funding to do this study, so we relied a lot on young researchers and students stepping up and helping out. What we did is that we jointly developed a survey instrument. We secured ethical approval in all the countries, and the survey was also field tested in each of the countries. And we did what was the only thing that was basically feasible at that time. We developed an online survey that we spread through our networks, partner organizations, social media channels, influencers, and we sent it out to the general population, basically. So this is what we call a convenience sample. There were a few of our countries that participated that did secure some funding and were able to set up a representative sample. But most countries used a convenience sample. We measured impact of the COVID epidemic on several aspects of SRH, basically sexual behavior, access to reproductive health services, STI, HIV treatment and testing, harmful cultural practices such as forced marriage and FGM, and also on mental health. For this presentation, I will of course focus on the contraception part, and the abortion part that you can see is only a small part of the study. We asked the respondents that participated in this study to report on their behavior at the time of the survey, but also to compare it with 3 months before the COVID pandemic. So we have some sort of comparison point and we can see whether there is actual change happening due to COVID. Over the 30 countries, we have over 23,000 respondents, but today we will focus on a sub-sample of this group. We will focus on European women of reproductive age because we're looking at contraceptive use. This means that in the numbers that you will see in the next slide, we are focusing on about 7,500 respondents, relatively young women, 31 years of age, mostly living in urban or semi-urban areas, and most of them have completed or have had some higher education. And this reiterates what Neil has said before, that we are biased, our study is biased towards young urban and higher educated population, and we may miss out on some particularly vulnerable groups that are really important to target and that may be left out in the study. We include in the numbers in the next slide data from 10 countries. That's the Czech Republic, Denmark, France, Germany, Italy, Latvia, Luxembourg, Moldova, Portugal, and Sweden. We have lumped these data together, but I'll mention at several points that there's quite a few differences between these countries, of course. Before I talk about contraception, it's, I think, important to also look at fertility intentions. And we asked women whether COVID has actually made them change their mind about having a child or not. And we see that the majority did not change their plans, but there is still 8.5% of women in Europe that decided to postpone having a child. A few of them also mentioned that they actually sped up the process of wanting to have a child. And we see important differences between countries. If we see, for example, in Denmark, it's only 2.7%. In Moldova, this was 15%. And in particular, if you compare this to other world regions, so for example, Sub-Saharan Africa has a lot more women deciding to postpone having a child than in Europe and in other regions, basically. When it comes to contraceptive barriers, we found that overall 6% of the women that needed contraceptives were hindered in accessing them. This means that they either could not access it or they were delayed in accessing contraceptives. The highest percentages were found in France and Italy, with up to 10% of women needing contraceptives saying that they were hindered. We also asked about the main reasons why they experienced delays or problems accessing contraceptives, and these arranged and I ordered them in terms of importance. So the most reported reason was that the healthcare center was not accessible. This was often mentioned, women are afraid to get COVID and therefore avoid going outside and seeking help. The health professional was not available, the method was not in stock, there was no transport to get to the facility. They were not allowed to leave the house, the pharmacy was closed, or they can no longer afford it. We also asked about where women are accessing contraceptives, and in this analysis, in these numbers, we only included women that sought contraceptives both before and during COVID. The numbers are pretty small, but you can see a few trends, or they're indicative to a few trends that are also highlighted in the previous presentation, actually. So we see that less women are seeking contraceptives from the family physician, from the hospital, or from community health centers, and that there's increases, there are small increases, but there are increases in access through online services, phone services, or directly through the pharmacy. Abortion, these numbers are really small, so it's difficult to say something conclusive, because in the entire sample in Europe that we recruited, we only found a bit less than 60 respondents that were in need of an abortion, yet we see that a substantial proportion of them was actually hindered and experienced delays in accessing abortion care. So in conclusion, this gives you a first taste of the potential impact of COVID from the population's perspective. It seems limited, but yet even these small numbers can have important consequences and life-changing consequences for women themselves. And I also want to reiterate the fact that we are working with a specific subsample of the population that is biased and that may hide subgroups that are not represented in this. Very quickly, what is maybe interesting for you to know as well, that with the support of UNFPA Eastern Europe and Central Asia, there's 2 other studies going at the moment. One is the Leaving No One Behind study, that it's specifically looking at access to contraceptives among vulnerable groups, that is women living with a disability, women living with HIV, or women that are victims of partner violence. And this study is led by the East European Institute for Reproductive Health. We are supporting the study with the Answer Network. And then a second study is the iShare 2, where we are doing the same study as I just presented, but in 8 new countries in the region of Eastern Europe and Central Asia. Thank you very much.
I thank you very much, Christine. I think what we can say in conclusion about both these studies is that on the one hand, we have a quite poor situation concerning data, concerning evidence, and at the same time, quite clear evidence that there is a huge impact of the COVID pandemic, also the sexual and reproductive lives of people all over Europe. So all over Europe is the next step. We will move now from Belgium to other parts of Europe, where 4 to be precise, members of parliament will share their experience, what they witnessed in their countries in this respect. And it's my pleasure to hand over to Leah. She is member of our executive committee and MP in Italy. Leah, please.
Well, thank you very much, Petra. I'm really happy to be here. I wonder whether you can hear me fine.
Perfect, perfect.
Okay. Great. I'm very happy to be here today, and I think the work that EPF has done should be actually extended to a discussion on vaccination and sexual and reproductive health. But I will come to this at the end of my brief part. Well, I'll speak about Italy, and for once, the fact that Italy responded to the EPF survey has to do probably with the fact that we actually managed to push for two major results in making the provision of contraception more flexible, thanks to the pandemic. But yes, it is thanks to the pandemic. On the one hand, we made the RU 486 available as main contraceptive measure in hospitals throughout the entire national territory. In the past, it used to be something decided by the regions, while thanks to questioning to the government and pressure on the government, we managed to make it the #1 method of abortion. Of course, this is abortion is not completely connected to contraception, but it is connected to an extent. In any case, our government made national guidelines for it to be used in whole hospitals without waiting for regions to decide on this. And this really has changed a lot the possibility of women to have access to their sexual and reproductive rights. The second thing is that, again, thanks to COVID, but not only, we managed to allow minors between the age of 16 and 18 to buy the day after pill in pharmacies, which was another big result that we obtained, and that really improves access to contraception in Italy. However, on the other hand, we haven't seen any kind of steps forward in the other barriers that the report suggests that have been raised due to COVID. So the fact that people are not going to the fear of COVID-19 with respect to going to places connected to contraception, social and sexual and reproductive rights. We have seen a dramatic decrease in opening hours in clinics and day clinics in Italy connected to COVID. Of course, there hasn't been a clear communication about, or there has been a clear communication, but at later stages of the pandemic, and this communication has not been from the government, but from doctors' associations. And we've seen, of course, as everywhere else, the increase in financial barriers, especially for women that lost their job. Italy is the country where COVID-19 has hit hardest on women employment in Europe. So I assume that financial barriers have increased a lot. And here I will come to the conclusion, and there are three conclusions. For one, has to do with COVID emergency. A lot of in the beginning, we thought that COVID emergency was an emergency, was a one-off, that we wouldn't see it happening again. But 2 years in the pandemics, we know that this is not the case. So we should really push for some enabling factors connected to COVID to become structural factors of the access to the pandemic. So we should really use the pandemic for the enabling factors to be accepted and used as a standard practice to increase access to contraception. Second point, it has to do with, as I said, with vaccination. We hear that there might be some connection between period and vaccination, but this part of the research hasn't been studied at all. And I think it is important for a forum like EPF to bring clarity in the relationship between vaccination and periods, and in general in sexual and reproductive rights of women. The fact that there hasn't been any study on gender medicine connected to vaccination, I think is a big gap in how we approached COVID from our point of view. And so I think we should push for this. And third point, it would be good to understand whether a forum like ours can really help, especially on mental health issues, which are connected to awareness on sexual and reproductive rights and the use of contraception. The report doesn't focus on this, but and now we've seen that this is a major issue, especially on women. And it would be good if we could think a little bit more on this issue of mental health issues connected to access of contraception, and in general on women awareness of their health and their access to contraception and fertility choices. Thank you very much.
Thanks a lot, Leah. So to summarize, you can also witness about all the obstacles that were mentioned in the reports, but you also made some progress in Italy in these two cases in accessibility of pharmaceutical abortion and for minors to the day after bill. Do you already have an idea whether these two things will stay even after the pandemic, or is this just for the period of the pandemic?
They will remain.
Okay, that's good.
Which is good. That's why I'm saying that it is very good to see that some things that we pushed forward have been accepted as standard practice. And I think that the report outlines 5 enabling factors that we should push more for them to become standard practice as well.
Okay, great. All the best for that. And we will try to join forces, of course, all over Europe to keep that. So now over to Anda Jaksa. She is a member of the Latvian Parliament, and she is also chair of the Latvia All-Party Parliamentary Group on Population and Development. So Anda, the floor is yours.
Hello, do you hear me well? Okay, thank you. I'm really happy to be here, and I think it's very important that we all are committed to protecting the sexual and reproductive health of the world's most vulnerable people, and also exchange our experience how we can protect the sexual and reproductive rights as best as we can. COVID-19 has immensely impacted the whole healthcare system, and it's in different sectors, and with restrictions, including social distancing and shutting down different sectors entirely. Sexual and reproductive health is a sector that should always be accessible, especially to its young audience. And therefore, I think one of the very good things, but right now is in Latvia, it was starting from 2017. It's an e-prescription, but allowed to access contraceptives. Access to modern methods of contraception is critical for young people to make decisions about their bodies, and we must ensure that abortion is the absolute last solution for anyone, and we can avoid such a decision by ensuring access to contraception. And therefore, I think there is two quite big barriers, but we realize it's information and also knowledge which is given at schools. Also that we are here, we understand that there was not enough access to contraception and long-acting reversible contraceptives. And the situation in all countries are different, but if we are looking at Latvia, then the services on daycare clinics was stopped, and also there was not enough services for consultancy for reproductive issues. And one good thing was telemedicine, which allow people get some consultation, some counseling on reproductive things. But as we see from report, it wasn't enough. It was not enough information how we can help the best place where to get this consultation. As also we see that about 33% women said that their appointments were rescheduled or cancelled, but mostly 76% women were satisfied with the accessibility of sexual and reproductive health care services. It's the issue of how to provide services in all country, and how to organize and reimburse the telemedicine services. Sometimes we see that decision makers live only in tunnel of COVID-19 and forget about other issues, about chronic diseases and about this reproductive things. And we are women in parliament all the time should make ensure that it's important is not forget. One more barrier maybe during the COVID times that NGOs, which are usually a big part of representing different social groups, were basically excluded from the decision making, especially at the beginning. And I think it was not very good. The main conclusion are that sexual and reproductive health services, which include safe methods of contraceptives and HIV testing and curing, overlooking of pregnancy, stopping and of unwanted pregnancies, infertility, caring and support and help, including psychological, medical help for victims of sexual assault and consultations about sexual and reproductive health should be guaranteed at all times, because of state of emergency can only worsen a person's well-being. The second main conclusion is the need for clear communication and education topics regarding sexual and reproductive health, and people need to be informed about the existence of such information, and it should be freely available for everyone. While making decisions that impact every single member of society at such levels that decisions about sexual and reproductive health services and supply and accessibility of products, not only the decision makers need to take into account every possible situation that the person could be restricted a decision over their own body, but different social groups should be represented, and that includes the male and female gender. Talking about contraceptions, we usually focus on females, but we really need to take into account that male gender, because women are not the only ones responsible for reproductive health, and everyone's need to be taken into account. In this case, it's need for contraception and say over their own bodies. Thank you.
I thank you very much, Anda, and it shows that it's indeed key that everybody has information and access to knowledge. And even if there are improvements, like in your case, telemedicine, if there is no information about how to have access to this telemedicine and how to use this new tool, it doesn't help anybody. So that's really, exactly, I think, two really crucial things. Yeah, exactly. As we already have now one request or one question, I would like to suggest you that we also give the floor to the two other MPs who are on the speaking list, and then I will give the floor to those who have questions. You already now, if you want to, can write your questions either in the chat, or you indicate in the chat that you would like to take the floor. You also can raise your question later than orally, and we will give you the possibility to speak and to get unmute. So now over to Katalin Denita. Good to see you again. We met in Copenhagen in August. Hello. Katalin is Member of Parliament from Romania. He is Vice Chair of the Committee for Human Rights, National Minorities and Cults. So please, the floor is yours.
Hello, Petra. It was a pleasure to meet you and all the other members of the EPF in Copenhagen at the Pride event, and also the Human Rights conference related to LGBT issues. It's a bit complicated when I was asked to talk a bit about the situation in Romania regarding the long-term contraceptive methods. My initial try was to, let's say, to summarize what we had in the previous epoch before the COVID. And I'll try to summarize a bit this issue, because I think in Romania we have a structural issue related to the contraceptive methods that comes not from the last year or the let's say the COVID challenges, but from, let's say, from our communist and post-communist past. So basically what happened in Romania, we don't have a real culture of the contraception. In fact, for the last 20-something years of the communists, basically all kinds of methods of contraception were basically forbidden, very hard to procure. Of course, the abortion was totally forbidden, and something like between 10,000, the official figure, and 50,000 women died because of that, because of the illegal abortions. And what happened after the communist fall? Basically, the only method that people knew as contraceptive was abortion. And what happened now is that basically the general population had a very limited idea about the contraception, and also, let's say, the government and all the public authorities don't have some let's say some strategy related to contraception. And I'll give you just some figures. In Romania, we have just 119 medics that are specialized in family planning in a population of almost 20 millions. So basically, those are the people that are general practitioners with, let's say, a super specialization in family planning, and also OB-GYN specialists that are, let's say, working in some clinics. So the number is totally, let's say, is not enough for this kind of population. What happened? We had some efforts from the NGOs in the first, let's say, till 2010, but after that moment, a lot of the NGOs, let's say, moved to some other countries, because it was considered that Romania, being a member of European Union, has the ability and know-how to develop a contraception program, but is not so. We have a law, but that law doesn't work, because basically in Romania, and that's it's totally different from the other countries, all the contraceptive methods, meaning pills and devices, need to have an HTA approval. HTA meaning health technology assessment, which in the other countries of the European Union is not necessary. And because of that, basically at this moment, there is no contraceptive method that is subsidized or reimbursed for the people in the vulnerable categories. And basically, this is a private business in Romania. It's your business to procure your own contraceptive methods, no matter if you are poor or vulnerable, or you are from a young category of persons, or from a deprived community. And that's a very, very big problem. What we also have, it's basically, and I'm sure all of you knew this figure. Basically, we have the record figure in terms of birth rate of underage women. It's something, if I remember correctly, it's about 20% of the children born in Romania have mothers under 18, and about I think it's 3 or 4% of this of the total numbers of births. It's women, girls basically having less than 16 years of age. So in Romania, we don't have necessarily a problem related to the COVID. Of course, the COVID made the things even worse, but we have a structural problem related to what we didn't manage to solve in the last 15 years or so. So I think we need to focus on this direction, especially. Of course, we have the same problem as the ones talked by my colleagues in the previous speeches, related to informations, related to basically the fact that a lot of medics had offered limited access in the COVID period. Let's say the telemedicine was not working as it's supposed to be, or it should be. But let's say our baseline it's very, very low, and we need to increase it by increasing the numbers of specialists in family planning, offering some methods of free contraception devices or pills to the women in vulnerable categories. And also, what we don't have, one second, we don't have sexual education as a part of curricula, of the school curricula. We have some kinds of sexual education that is taken care of some NGOs, but we don't have in the curricula that we are teaching to the K-12 children. And what is even worse, basically, there is a clash at this moment in the parliament between the conservative MPs, and probably in this direction there are more than 60%, 60 to 70%, and let's say the parties that want to push for some kinds of sexual education that is not necessarily related to all kinds of themes, but is especially related to HPV and HIV diseases, is related to sexual abuses, and also related to underage pregnancies. So this is a general overview, and of course all the challenges of the COVID epoch pushed on this baseline and making it even worse. That's the situation in Romania, unfortunately. Thank you so much.
Okay, great. Thank you very much, Katalin, for this input and few insight. So I summarized that Romania has a structural problem when it comes to the subsidy of the access to contraceptives. Thank you also very much. Even if EVS EPF campaign for free, legal and safe abortion is not a means of contraception. Absolutely not. Yeah. And also I think that your numbers in teenage pregnancies are quite alarming also. Thank you very much for sharing that. And obviously Corona didn't make the situation better, but as the baseline was that low already, there was not a lot to lose. Let me frame it like that. Yeah. Okay. So thank you very much. And now we go to Great Britain. It's my pleasure to announce Dame Diana Johnson, who is a co-chair of the All-Party Parliamentary Group on Sexual and Reproductive Health in the British Parliament. Please, Diana. Okay. The floor is yours.
Thank you very much, and I'm really delighted to be with you today. So thank you very much for the invitation. So my name is Diana Johnson. I'm the Member of Parliament for Hull North, and I've been a Member of Parliament since 2005. And as a Member of Parliament, I've always been very interested and stood up for women's rights and a woman's right to choose. And in Parliament, I co-chair the All-Party Parliamentary Group for Sexual and Reproductive Healthcare. Now, the APPG on sexual and reproductive healthcare is a cross-party group of members of Parliament and members of the House of Lords, and it was established to facilitate discussion between parliamentarians and key stakeholders on sexual and reproductive health. The ability to decide whether or when to have a child is fundamental to the physical, psychological and social well-being of women. However, for many, accessing contraception is becoming more difficult. So in 2019, the All-Party Group launched an inquiry to look at exactly that, to look at women's ability to access contraception in a way that meets their holistic needs, sexual and reproductive health needs. Now, before we were able to conclude that report, we were hit by COVID-19. And so the inquiry was extended to allow us to include what had happened during COVID-19 and the drastically altered landscape of healthcare and contraceptive care in the United Kingdom through COVID-19. So first of all, I just want to talk about that report and what we found. And I think the first point was that women are finding it harder to access contraception that suits them, and that situation was made worse by the pandemic. And we also found out, however, that there were some positive shifts in how women access contraceptive care as a result of COVID-19. And I am going to talk about both of these areas today. So to start off, to put it into context, the effects of the pandemic on the provision of contraception occurred on top of pre-existing challenges. Funding cuts and fragmented commissioning structures were already creating problems of access. And despite the best efforts of many practitioners, the COVID-19 pandemic highlighted these problems and further restricted access for many women. Now, there are three key issues that I want to highlight today. First of all, the inquiry heard that long-acting reversible contraception, or LARC fittings have been most severely impacted. We found that 54% of sexual and reproductive health services had ended or limited the provision of emergency LARC, and 39% had ended or limited provision for LARC complications. Now, this limits choice, and it means that women may end up using a form of contraception that is not well suited to their needs. We also found that access to emergency contraception is another area of concern. Some women have struggled to access oral emergency contraception in the early stages of the pandemic, when pharmacies were busy and clinics had not implemented clear guidelines. Finally, we know that marginalised groups have been particularly affected by restrictions in access to contraception. Our inquiry heard that some marginalised groups are more likely to access care via walk-in services, which have been disproportionately affected by COVID restrictions. We also know that services have reported a drop in the number of young and Black, Asian and minority ethnic people requesting care, which is of course deeply concerning. However, there have been some positive developments over the past 18 months, and I just want to outline those quickly. First of all, digital services and remote consultations have provided women with more options. Remote consultations for sexual and reproductive health care rose from 18% before the pandemic to 89% at the time of our report's publication. Now, these consultations provided a far more convenient form of access to contraceptive care for some, and for many, this helped to alleviate the stigma which may be associated with visiting a clinic. However, face-to-face care is still crucial to ensuring women can access care. Another positive development we've seen is that some women can get prescriptions of their oral contraception posted to them or collect them from their local pharmacy. For women for whom English is not their first language, online services may be easier to access than services which require face-to-face interaction. And finally, whilst we're focusing on contraception today, I want to highlight the success of telemedical abortion services. Women are now able to access a safe and effective service from their own home. And this has been particularly beneficial for those who may well be vulnerable, including women who are at risk of violence and abuse. And we very much hope to see these measures made permanent in England, Wales and Scotland over the coming months. So what can and needs to be done next? Well, first of all, the restoration of services after the COVID-19 pandemic does provide a unique opportunity. We must reshape contraceptive services according to the needs of women themselves and make more efficient use of NHS resources. There are countless opportunities to improve access. Offering contraception, for example, as part of maternity services, this results in a higher uptake and means that new mums don't have the additional stress of navigating the system with a babe in arms. And additionally, there is scope to make vast improvements in data collection and monitoring, which will greatly assist in making improvements across sexual and reproductive health services. It's also important to consider how best to integrate sexual and reproductive health care into existing women's healthcare pathways in the NHS. So by integrating care around the needs of the individual woman, we would remove institutional silos and the subsequent obstacles that many women face. We hope to see these recommendations from our report reflected in the Department of Health's upcoming sexual and reproductive health strategy, and they're also producing a women's health strategy. And this will be a landmark moment in deciding the future of contraceptive care in the United Kingdom. So thank you again for inviting me. Thank you for taking the time to listen to me today. And if you would like to read our report in full, you can find it on our Twitter or our webpage or on the Faculty of Sexual and Reproductive Health's website. Thank you.
I thank you very much. So also to summarize, we can say that in a nutshell, like in diverse different other fields, COVID acted like a magnifying glass, and those problems that existed previous also are there now, and even harder for those who are affected by it. And may I also ask, I didn't get it totally clear, these issues where you think there was an improvement, do you know whether they will stay, like telemedicine, prescriptions by post and to pharmacies and things like that?
That's a very good question, and the issue is that the government have said initially they said no. The telemedicine around abortion was just for the COVID-19 period, and once the pandemic had gone, we would revert back to our laws, which require a woman to attend a clinic to get abortion services. However, I think the evidence is showing that this service has worked well. Women have been able to access it. The clinicians are saying this works well. And so the government have agreed they would undertake a consultation. They would look at the evidence. They would ask the public what they thought about this. So we are now waiting. The consultation has closed, and we're waiting to hear from the government what they plan to do. But we're very we believe this is a very positive step forward, and we're keeping everything crossed that they will keep with this new change. Yes.
Yes, indeed, that's really a good step forward, and all the best, much energy for your negotiations to keep all these improvements. So we now have about 25 minutes for questions and answers. I have to line out that both Catalin from Romania and Christine from the University of Ghent already had to leave our webinar. So in case you want to raise questions, please not do these too. So it's good that my good friend Daniela Dragici didn't ask something to Catalin, but just made a statement in the chat, because Catalin wouldn't be able to answer anymore. But there was another question to Leah from Blandine Mollard. It's about how the connection between mental health and sexual and reproductive health issues. And Leah, may I ask you to elaborate a little bit about that?
Yes, I written a little on the chat. But
not everybody can see this chat you used, so please do it again.
Basically, I think this is a connection that should be further investigated. We all know that whenever women don't feel well, their ability to access services connected to their sexual and reproductive health decrease. And I think there could be, it's an hypothesis, but there could be a magnifying effect of this when the unwellness is connected to the fact that they're mentally unwell. So the fact that women are less aware of themselves and so on might decrease their ability and their will to seek help for contraception or to decide about taking contraception. So I think this should be investigated, especially because mental health issues will remain with us in an increased way in the years to come. So we will have to face this as one of the consequences of COVID. So I think it would be interesting, at least at a forum like ours, investigates on this, and then we see what we can do about this.
Okay, thank you very much for answering that. And there was another question to Diana Johnson from Alison Slingsby about the number, the concrete percentage of women who are struggling with access. Can you maybe elaborate on that?
Well, what I can say is I'm going to have to go away and check the figure. What I do recall from the report, because it was a little while ago when we published, was at the beginning of the pandemic, it was much more difficult because obviously services were so disrupted, shops were not open, pharmacies were not open. It was all very difficult at the outset. I think that's settled down, but I will check the report and I will feed back in the percentage. But I can't recall off the top of my head exactly what it was.
But as you mentioned, the report is publicly available on your website, so everybody can. Maybe you can post a link, in the chat. That would be great. That. Yeah, that's great. Thank you very much. Then we have Silviu Serban from Romania, who says he can take the questions from Katalin if there are any. Thank you very much for that. And he also asks for any advice or support, as we realized that indeed after NGOs have left Romania after accession to the European Union, there is a need, or there is a void that these living NGOs left, and there is still lack for support and financial support as well for subsidies on this issue. So if anybody has some good advice on that, please also let us know and share. I think that Blandine is happy with the answer from Leah. Thank you very much. Are there any other questions, or would you simply like Daniela? Thank you very much, Daniela. Would you like to say something, in case you would like to say something, Daniela? And as I know you would like to say something, we can give you the floor as well. So you already can unmute yourself and tell us.
Well, greetings, first of all, from Romania. This is a great honor. Thank you very much for your kind words. Thank you for the report. Thank you for the timely event. The situation in Romania is even more critical than Katalin described it, frankly. At this point in time, we no longer have family planning clinics. The number decreased from 252 to 117. And only 2 of these still have contraceptives. Only 1 in Bucharest, the capital city of Romania, which is absolutely outrageous. Forget, free contraceptives for vulnerable populations. And the Ministry of Health, unfortunately, is not able to deal with this issue for more than 4 years because of some technical glitch that I think Katalin described. And also, there is no plan, even through the National Resilience Plan, to do anything about contraceptives, because the money is not prepared, is not actually allocated for anything like that. But fortunately, about 100 family planning clinics are going to be rehabilitated in Romania, according to a proposal that actually NGOs, the NGO that I'm involved in, proposed to the Ministry of Health, and thank God they accepted it. But how can you have just services with no contraceptives at clinic level, especially for vulnerable populations? And even yesterday, the Parliament of Romania still debated what to call the sexuality education that is so much needed in schools, whether to call it sanitary education or life skills education or health education or whatever. Instead of debating over language and terminology and what to call it, they should just start doing it with the help of the NGOs that are really very well prepared in Romania to deliver these classes. Thank you very much. That is maybe the good and bad news at the same time from my part, the NGO sector in Romania.
Thank you very much, Daniela. you're totally right. The situation sounds really very urgent and very urgent that something more happens indeed. As you might not know, but EPF is not an organization that provides services as such. We really work on a political level. We make advocacy work. We try to change laws. But I know that Daniela knows that IPPF is the one who hopefully can be supportive on that, even if I do not know exactly about the priorities of IPPF European network at the moment. And Daniela also asked about whether we can share the PowerPoint presentations. I think we can do so. I see Neil nodding. And I also have another question from where is it? It was also to Diana, but I can't find it anymore. It maybe is here now. Yeah, it was a question by Antonia Lewandowska. Thank you very much for the feedback on the event and on the insights. And she asked Diana, what's the situation regarding medical abortion? What is a preferred method since it was introduced, and how the developments have been there, and how the pills is distributed? So can you please answer to that, Diana?
So since COVID, we've had this opportunity that women do not have to attend a clinic. They can seek advice over the telephone, over the internet. And so what we do know is that the majority of women think that's better. In the UK or in England and Wales, we have a law that governs abortion, which basically has quite strict requirements in terms of you have to attend a clinic, you have to be seen by 2 doctors, or they have to sign off to say the abortion is required. And what the telemedicine abortion now means is that for women, it's easier to be able to get access to services. And the evidence that we've seen is that that's actually good for women. I think women are coming forward and abortions are taking place earlier on than if they're having to wait for appointments to go to a clinic. So the issue, I think, is that when you look at the statistics generally, we know that the vast majority of abortions are medical abortions. They're taking tablets. It's not surgical procedures that are being undertaken. So the tablets are being provided for women. They can take them at home. They can take them at a time that's most suitable for them, when they can rest and be at home, because there's always been in the past an issue about women having to take tablets in the clinic and then have to travel home. And of course, some women don't live close to clinics and they have to travel a long way. And there's all of that to consider. So at the moment, under the provisions brought in because of COVID, telemedicine abortion is available. As I said earlier on, we're waiting to see whether that will carry on. If it doesn't, then we will revert back to women having to attend at a clinic to get that first appointment with a clinician or a midwife.
Thank you very much, Diana, not just for answering the question, also for sharing the link to your reports of your all-party group. Are there any other questions? I do not see any new ones for the moment. So in case you would take the opportunity, we still have a quarter of an hour to go. If you would like to raise another question, if you would like to comment on whomever, please take the opportunity. And I saw that also Remy shared the link. Thank you. I do not see anybody asking for the floor now. So may I ask Neil whether you would, you raised your hand, sorry, I just saw it at the moment. Neil, please.
Yeah. Thank you, Petra, and thank you also to all the members of Parliament from from the UK, from Italy, from Latvia, and from Romania for the great interventions. I just, since we have a little bit of time, I just wanted to take this opportunity to emphasize a few key recommendations. I already formulated them, but I mean, already it's important to emphasize that one of the things that could have the most beneficial effect for the most number of women would be for those countries where contraception is not covered by the national health insurance to have this be covered. This is like this, and it's like this in all of the best performing countries, but it's not like this across Europe. And this is, contraception is something that affects every woman. She'll need it for most of her life, and there are easy solutions for this. Another recommendation is, and it came out through the different country interventions from the honorable MPs, is that governments should communicate more proactively on how to access contraception. In the times of COVID, there was uncertainty about contraception, but about everything. We all remember, you know, the changing rules: wear a mask this week, next week you don't have to wear a mask, etc. And this affected access to SRHR services as well. But then more generally, what we see is that in some countries, governments are good at providing information on contraception. The UK is one of them. France and Belgium are other examples of good, authoritative, clean information. But in other countries, there's nothing. And this allows for misconceptions to reign rampant, which contribute to this, you know, this culture of not using contraception that Honorable Tinita from Romania mentioned. So I think already those are two things that really are within the realm of policymakers that could make a real impact.
Yes, indeed. And that's, of course, also an opportunity for us to learn from each other how we manage to keep this progress that we saw during COVID. And that's not a lot, but it is some at least, really to keep that and to bring that over also into a period after. When we build forward better, not to build back better, because I think we also should look on forward developments. Okay, so let me one more look whether, yeah, there is a new question from Christiana Puig-Boras. She asked whether we can expect the European Union institutions to implement the report recommendations. Do you think that COVID crisis will change the approach the EU has to SRHR, or bring us closer to this change? I think at the moment we do not have any member of the European Parliament with us, but if I look back to June and see that the Matic report was adopted quite clearly, which really asked for clear progress in access to SRHR services, then I think there could be a progress, or the Matic report at least could be a basis for next step in the right direction. But I see that Neil is also ready to answer on this question.
Thank you, Petra. And also thank you for raising the Matic report. I think what we've just heard today, and the different examples from different countries, as well as our report, the report from the University of Ghent, and also this important report from the European Parliament on sexual and reproductive health and rights adopted in June this year. What we have there are the political asks in relation to sexual reproductive health and rights and contraception specifically. And so there, the public bodies know what needs to be done. What is missing now is how to get this done at the level of different countries. And for most of these things, the solutions will not be found in EU institutions, because the EU institutions simply don't have the competence for this. So the solutions have to be found at national level. And so it's different national level actors that need to get together, civil society with policymakers and other experts, etc., to really think through, this is a priority for my country. We need to do this and the other thing. We have these allies in parliament and in the government. We can advance this during these next couple of months or years. I think that's what needs to happen. But at EU level, everything has been done that can be done, more or less. We have the political direction. Now is really how to push this at national level in Romania, in Italy, in Latvia, etc., to make this become a reality.
And I can add that as EPF covers not only the European Union, but also the Council of Europe, with much more countries, with 47, including Great Britain, for instance, and Russia and Turkey and many others. I also can, but I will not be able in parallel to provide you with the link, I'm afraid. But I had a report at the Council of Europe last year about the access to contraception, modern contraception, and to evidence-based and comprehensive sexuality education, which doesn't has any legal binding provisions for any country, for any member country, but gives recommendation how we could improve also at the broader scope of the Council of Europe. And at least the European Court of Human Rights has to share our opinion on this when there come cases, which can be important if, for instance, parents do not want their children to attend sexuality education at school, where we had cases already before. So we try to use, thank you very much, Marina, for sharing the link at the chat to my reports. Great. No, yeah, it is it. Yeah, so thank you very much on that. So we are trying to work on different levels of policy to improve the situation. So, okay. Yeah, I think there is no common sense on what shall be the competences of the European Union and what shall stay within national legislation only. So that's an ongoing debate in parallel, of course, yeah, which we cannot influence that much, to be honest. Okay, so as all the questions seem to be answered and all those who raised the questions seem to be happy by saying thank you very much for elaborating on this and that, I think we are done with our webinar. I really would like to thank all of you for the participation, the active participation, for your interest. And whenever you have anything connected with sexual and reproductive health and rights, please get in contact with us, get in contact with EPF. We are happy to work with you. We are happy to cooperate. And it's not a question of happiness. It's simply a question that we have to join our forces to have a bigger impact for the fundamental rights of men and women when it comes to sexual and reproductive rights and services. So yeah, let's do so, and let's try to make the place a better world for men and women and their sexual and reproductive lives, which all of us also has, of course. So I wish you a great afternoon. Thanks, and see you hopefully soon, and hopefully also in person again, at least some of you. Okay, bye. Ciao, thank you.
Thank you, bye-bye.
Yes.
I will keep all my enthusiasm, Daniela, no question. Bye.
Bye.